All right, hello everyone around the world. A warm welcome to our webinar autumn session today that is again all about fetal cardiac imaging using MRI. A short note that this webinar will be recorded again as each of our webinars, and this will be then available on our website afterwards. I'm happy to have Malenka Bissell with me today from the Leeds University, and she's moderating the session together with myself. Welcome, Malenka, already. Especially for those that might attend our webinar today for the first time, I would like to highlight that even though there are meanwhile already more than 95 devices in the market, it is still our aim to build a community and to offer a platform for networking and exchange, as fetal cardiac MRI is still new and innovative, and there is high potential of learning from each other. That's our aim, and that's why we are here today. You are all very welcome to actively participate and to discuss during this webinar. Therefore, just simply please raise your finger to show us that you want to talk. And you can also please paste your questions directly into the chat or also use the Q&A function. Most of you might know or might be aware of our magazine that contains all latest news from the world of fetal cardiac MRI. There are two versions out already, one from 2024 and the other one from 2025. And we are now starting to create the third version that will be released in January 2026. And yeah, dear everyone, this is your chance to share your insight with the worldwide community. So if you have any content, or maybe you have even a special MRI image that has potential for being a cover image, then please contact us, let us know, and we are very happy then to integrate your insights into this new magazine version. Having said that, I want to jump to our session today. It's our autumn session. It's called Shaping the Future of Fetal Cardiac MRI. It is an expert consensus on clinical key indications. The content for the session today is part of an outcome of the second fetal cardiology MRI workshop. We had this workshop in this summer in Hazelwood Castle, organized by Malenka. This was a great event with a warm and family-like atmosphere with room for intense and in-depth discussions. We have shared their recent developments. We have presented clinical cases by each side almost. We have discussed potential improvements and limitations, as well as presented ongoing research. And during the last part of the workshop, we have defined clinical indications by expert groups. And we did that by having a poll. They have been defined actually by using a poll. And those 5 clinical indications are the ones that have been chosen as being the most common ones. And we will focus on those 5 clinical indications today in our webinar session. And those will be presented by 5 experts. The first one, cardiac mass, will be presented by Richard Friesen. The second one, heterotaxy by Sally Anclure. Then the HLHS will be presented by Mansi Gaitondi. Border left ventricle by Eleanor Schuchard. And last but not least, COA by David Lloyd. Probably we will change the order at the end, but that's what we will decide. We'll just do later. Now we start, and I'd like to hand over to Richard with the first one, cardiac mass. Thank you, Richard, for being here.
Thank you for having me, and thank you to Heide and Malenka for organizing this. I'm going to share my screen now.
Yeah.
All right.
Perfect. I can see that.
Can everyone see that okay?
Yeah.
Okay.
That's good.
So, my portion is talking about fetal cardiac masses. And so today we're going to review the indications for fetal cardiac MRI and the prenatal evaluation of cardiac masses. suggested useful sequences for the evaluation, key reporting elements for a fetal cardiac MRI report, followed by a couple case examples. A detailed review of fetal cardiac masses in general is a little bit outside of the scope of the time frame, but would be great for a future talk. So in general, congenital cardiac masses, primary cardiac masses are rare, with prevalence sort of being reported in the 0.0017 to 0.28%. But improved prenatal imaging has increased the prenatal detection. So through improved the fetal ultrasound and fetal echocardiography, and certainly with the advent of fetal cardiac MRI, the evaluation and detection of cardiac masses has increased. Looking at different cardiac masses types, so rhabdomyoma is by far the most common. So reports estimate sort of the 60 to 86% of cardiac masses that are detected prenatally are rhabdomyomas, with association with tuberous sclerosis, with brain and renal abnormalities also being able to be seen on fetal MRI. Other primary cardiac masses, teratomas, fibromas, hemangiomas, hamartomas, lipomas, and myxomas, among others, have been seen and reported, but are certainly much rarer than a rhabdomyoma. So what's the utility of a cardiac MRI fetally for the evaluation of cardiac masses? So the key is, when the evaluation of a cardiac mass, is we want to know, where is it? How many are there? What kind of mass do we think it is? How is it affecting the fetus now in utero by impacting blood flow or surrounding structures? Or how may it potentially affect the fetus after birth? And are there any other abnormalities outside of the heart that can give more diagnostic insight, as I mentioned in the evaluation of extracardiac findings in tuberous sclerosis? So how do we do that in a fetal MRI? And I'll show a couple case examples later, but when we're looking at what type of sequences is recommended to be performed or included in our fetal cardiac MRI evaluation of a mass, the T2 weighted turbospin echo black blood stacks throughout the fetus in multiple planes certainly is kind of the workhorse of fetal MRI, but this gives us a full evaluation of the fetal anatomy in general. It can also help us locate the mass and how it interacts with surrounding structures. A good look at the airways with our black blood imaging, and certainly for those types of masses that have impact into the pulmonary space, or taking up a large portion of the thorax, you can use a 3D sliced volume reconstruction for lung volume assessment, for intrathoracic masses that are impacting those lung and airways. And certainly you can use your T2 weighted imaging for brain evaluation as well. Our balanced SSFP, static, and cine imaging gives us a little bit more tissue contrast, so we can help localize the mass within the heart, see how it impacts ventricular function, looking for obstruction to blood flow, and being able to see how it interacts within the heart with our cine images. T1 fat sat and T2 sequences, as mentioned above, also give us a little bit more insight into tissue characterization that we would commonly perform in postnatal evaluation of cardiac masses. Flow analysis is can certainly be included in this. It may not be as important in some of the other more complex physiologically cardiac lesions that we'll see a little bit later in this presentation, but it can give you a hemodynamic assessment of fetal circulation. So this can estimate impact on cardiac output. Certainly, if there is a large blood supply to a vascular mass, you may see some flow analysis to this, but our 4D flow for very small vascular tissues is really limited by our spatial resolution. So in our reporting, we really want to have a description of the mass. Where is it? How big is it? Are there more than one mass? what can we glean from our sequences to characterize the tissue for what kind of mass this may be? Is there evidence of vascularity or blood supply? And how is this impacting cardiac function? Is there any intracardiac flow obstruction, extracardiac flow obstruction, and is this impacting ventricular volumes or function? And then how is it impacting surrounding structures? So is there obstruction or mass effect on extracardiac vasculature or airway? And then for the additional features, certainly with cardiac masses, that puts the fetus at increased risk for pericardial pleural effusions or hydrops. And so we want to add these features to the report as they're at risk for hydrops, lung volumes, as I mentioned, and other extracardiac findings. An estimated fetal weight and a fetal heart rate also are important for reporting. The limitations, obviously, for with the lack of contrast agents for improved tissue characterization. And so this is a limitation in our comparison to postnatal evaluation of cardiac masses. So we can't do our first pass perfusion or delayed enhancement currently. And certainly if there's associated arrhythmias, that can present issues for cardiac gating. And T1 and T2 parametric mapping, we don't have clear normative data for fetal myocardium. So we'll move on to some pictures because that's a lot of words so far. So our first case is a 30-week fetus with a cardiac mass that was detected in the second trimester. This patient had intermittent hydrops with requiring a pericardiocentesis in the second trimester, and there was concern for impaired cardiac function due to the mass pressing on the heart and extracardiac structures. So it was referred for a fetal CMR for characterization of this mass and its relation to cardiac structure. So in our left panel, we see a cardiac-gated SSFP Cine imaging. And we see our heart being compressed by this mass. And as it comes through, we see this really large heterogeneous cystic structure taking up a large portion of the anterior thorax, really compressing the cardiac structures that are seen sort of pushed posteriorly. Our black blood T2 images, we can see this heterogeneous cystic structure, and if this scrolls through, we can see its impact on the vasculature. And then you can get an estimation of the fetal mass and how much of this fetal mass takes up of that space. So looking at this in a little bit more detail, we can see that the SVC, aortic arch, the pulmonary artery, ductus arteriosus, and descending aorta are all squished posteriorly along with the cardiac structures inferiorly. So there was concern for postnatal hemodynamic compromise shortly after delivery. So we were able to estimate that the cardiac mass was about 5% of the total fetal mass. Describe the structure in a little bit more detail with a cystic mass on T2-weighted and SSFP images and show that there's compression of cardiac structures. We were also able to estimate the cardiac output and match that up with the estimated cardiac output by fetal echo and found good correlation by ventricular function and flow analysis. So the fetus underwent an exit procedure with a resection at 34 weeks. But the way that this helped is that we aided in the diagnosis of a pericardial teratoma. And importantly, for delivery planning, we were able to estimate a baseline cardiac output and demonstrated that there was adequate cardiac output even with the external compression of the cardiac structures, allowing the team to monitor for cardiac output and monitor for changes by echo to delay delivery for a little bit more maturation of the fetus from 30 to 34 weeks. So we were able to provide that reassurance to delay delivery to allow more growth, and it helped the surgeons with preoperative planning by clarifying some of the tumor margins and attachments to vascular structures. And quickly, I will show a rhabdomyoma before we move on, since this is the most common. This is courtesy of Dr. Schuchart at Rady Children's. This was a twin gestation with one of them noting multiple cardiac masses and concern for tuberous sclerosis on ultrasound brain imaging. Using our different sequences, so we see our Cine imaging, we see this large mass that is iso-intense to the myocardium around it, right in the interventricular septum. we were able to assess that there's decreased left ventricular systolic function. It was iso-intense on this T1 and SSIP imaging, and then noted to be a little bit hyper intense on our T2 weighted imaging, which is more consistent with a rhabdomyoma. And then the addition of neurologic imaging in this also showed characteristic findings consistent with tuberous sclerosis. So this allowed the family to get better prenatal counseling and understanding of tuberous sclerosis. In large rhabdomyomas, this may help with guide prenatal treatment. For obstructive rhabdomyomas, it improves prenatal counseling and certainly helps with delivery planning for postnatal interventions and considerations. And a thank you to the rest of the team, and I will stop there.
Thank you very much.
Thank you, Richard.
We haven't got any questions at the moment. So Heidi, in the interest of time, shall we carry on for now and see whether any more questions come through as we go through the other cases?
Yes, I agree to that. So we jump already over to the next indication, which is heterotaxy, and presented by Sally Ann. Thank you, Sally, for sharing your screen.
Thank you very much for the chance to share my case. I'm just trying to get it on. I should be able to see it now. Can you see it?
Yes.
Good.
Perfect.
All right. As has been said, I will discuss the role of fetal cardiac MRI in heterotaxia. I think the major benefit comes in the answering of two important questions. Are we dealing with a critical cardiac lesion or not that may be dependent on one of the important essential prenatal shunts, such as the foramen ovale, the arterial duct, or the venous duct? We want to know if we've got a problem with our pulmonary venous return, and if we are going to be able to correct this baby with a biventricular repair, or if this baby has to follow a univentricular pathway. And it's especially helpful in situations when we have poor visualization, a poor echo window, an overweight mother, or a presentation late in pregnancy. With regards to the protocol, I just need to move this out of the way. We would do black bloods, including the abdominal organs and the lungs in this case, because they are very relevant to our description of the type of isomerism that we are dealing with. Whole body baby net with breath hold. So this was a recent one that we performed, and we were quite close to the estimated fetal weight by ultrasound. We would do 4 deflow, but this requires a 6 minutes scanning time, and we have to use our Doppler gating. We would then repeat black blood, and then CNAs can be useful for evaluating the cardiac anatomy and the cardiac function. This was one of the cases that we recently have done. This thing is in the way. Where we had a left isomerism, so we can see the azygous vein behind the aorta here on the right side, when we see that there was a very big right ventricle, a small left ventricle, and there was atrioventricular valve regurgitation. In this case, there was a sinus bradycardia, so it's also a good idea to assess, to set the heart rate in your Doppler gating to the heart rate of the baby. So the case I wanted to present was seen at 28 weeks and 6 days. If we have a look at this cross-section through the abdomen, we can see that this case was a case with right atrial isomerism. We had a vena cava on the left side, an aorta on the left with the stomach on the right. If we have a look at the four-chamber view, you can see that there was also an atrioventricular septal defect here with a dominant anterior ventricle, small ventricle to the left of that, and this anterior ventricle had the configuration of a left ventricle. And coming out of that was a large aorta anteriorly. And behind the aorta, as we see on the right side, there were small pulmonary arteries coming out of the also the anterior ventricle. And if you look carefully, you can see there was a wiggly ductus giving retrograde flow to these pulmonary vessels. So we knew already that there was a significant pulmonary stenosis in this case. When we looked at the pulmonary veins, we could not really see them connecting to the atria. When we looked on the axial images and we scanned downward from the confluence, I'll just follow it. We're moving downward. We could follow this pulmonary vein all the way down into the liver, and it seemed to be connecting into the umbilical vein. And when we looked at the Doppler signal in the veins, it was abnormal, suggestive that we may be dealing with obstruction. So we did our black bloods, and they were a little bit blurry, but we were able to identify the fact that there was a left-sided vena cava, that there was another vessel going down through the diaphragm on the right side, and a right-sided aortic arch. The other pictures were rather blurry and didn't really help us so well, but it's a good lesson in this, because what we did was we also looked at the individual slices in our stacks, and then we were able to identify a pulmonary artery on the left and the right side. We could see the pulmonary veins coming together, and we could see a vessel going downward on the left side, as I said, towards the liver. And when we did our fetal flow, we had to rely again here on the magic of Regan Tompkins and Eric Schrauben. Regan is our motion correction magician, working with reducing the motion effects of maternal respiration, the heartbeat itself, and the baby's motions. And Eric makes our nice angiograms. So when we're interpreting our fetal MRI, we also need a little more magic here. And here I would recommend that interdisciplinary communication is very important. So this is the segmentation and the flow visualization of this patient. We can see here the anterior aorta coming out of the anterior ventricle. We see the ductus here in this left view. And if we have a look at the flow visualization, you can also see the flow in the arterial duct here. When we look on the other side, we can see that vessel going down towards the umbilical vein, and also on the flow visualization, you see the vessel going downwards. This is an oblique view, which allowed us to do contours in the umbilical vein, the vena cava inferior, and the pulmonary vein. And this allowed us to confirm that the flow of blood in that vessel going downward was indeed going down in the other direction to the vena cava inferior. So we were able to confirm in this case that we were dealing with total anomalous pulmonary venous drainage that was obstructed partially already with an abnormal Doppler flow, but it was dependent on the ductus venosus, which would close postnatally, so we had a critical heart defect. We also had a second reason to be concerned here that this was a critical heart defect, and that was the ductal-dependent pulmonary stenosis. So we organized that this baby was delivered in daytime in a center with cardiothoracic surgery facilities and intensive care, and neonatal intensive care facilities, was started directly on prostaglandins. The surgeon was ready. A total correction of the TAPVD was done on day 1. Later, we did a scan to confirm our diagnosis, and a surgery central shunt was done on the 4th day because of the pulmonary stenosis. So I just stop this here. I showed you this picture already. We can see exactly that in the postnatal CT scan that was performed here. Here are the pulmonary arteries. Here we see the 4 pulmonary veins that have now already been connected to the back of the atrium, and we see here the big vessel going downwards, which was towards our umbilical vein. When you are reporting in the case of heterotaxia, we need to have basic information about the demographics and cardiac outward axis, which is important because it tends to be abnormal in heterotaxia. We need to have important information about the abdominal organs. and the lungs especially. And we need to have a complete description of the cardiac anatomy, focusing on the systemic and pulmonary venous return, the great vessels and the arterial duct, and the pulmonary vascular bed. On the right here, I've got some pictures of a case with left isomerism. Again, we see the azygous vein behind the aorta. We can see that the left ventricle here is smaller than the right ventricle. We see that the pulmonary veins are nicely seen. This case had also a double outlet right ventricle with the aorta anterior, the pulmonary artery posterior. We can see the valve, and what you cannot see here is a duct. This baby had an absent arterial duct. So this was, again, helpful for us for deciding on the location for delivery of this baby, because this baby needed a postnatal prostaglandins. To the next page. So I've shown you a complex case with right atrial isomerism that had total anomalous pulmonary venous return to the umbilical vein, being then ductus venosus dependent, and another with severe pulmonary and also severe pulmonary stenosis, making this baby arterial duct dependent. I showed you that 4D flow with motion correction can be complementary to the anatomical scans. And here MRI allowed confirmation of the anatomy and gave additional information, allowing for decisions to be made regarding the location of the delivery and the immediate postnatal care needed. And I thank you very much for your attention. And of course, this is not a solo effort. Lots of people are involved in this project. Thank you very much.
Thank you very much, Sally-Ann. I think both you and Richard have shown very clearly how fetal MRI can really help with the perinatal decision-making and pre-planning management, and actually putting procedures, plans in place before those babies are born. I've recently had a chat with one of our adult cardiology colleagues about, why fetal MRI is important. I tried to explain to him, it's a bit like, somebody's going to have a heart attack. Wouldn't it be good to know how severe it's going to be and, how quickly you need to intervene? And then the penny kind of dropped that maybe it's a good idea. So I think both of those cases really represent quite nicely how fetal MRI can actually help to have a treatment plan in place before the baby's even born. We had one quick question back to Richard, if he's still there. Richard, are you still there? Yes. Any secondary sites of tumor burden? Was there any hydrops at 34 weeks in your first case?
There was, in the first case, there was a small pleural effusion and a small pericardial effusion. Those had been relatively stable since the pericardiocentesis. The baby had previously had some ascites, and then that sort of resolved a little bit after the pericardiocentesis. So they were watching it multiple times a week for evidence of worsening hydrops, but it was sort of a waxing and waning. And so we were able to see that there was a little bit of effusion that seemed similar to the fetal echo and a small pleural effusion, but not something that seemed to be worse than what they'd been seeing by echo, and we didn't see any ascites on the fetal MRI.
Thank you. Heidi, shall we carry on with the next case and then see what other questions come in?
Yes, let's do so.
Coming with a bit of delay.
Yeah, we continue with Mansi with the HLHS. Thank you, Mansi, for sharing your screen.
Excellent. All right, is everything sharing appropriately?
Yes.
Okay, perfect.
I can see your slides. Perfect.
Thank you. Awesome. All right, so this moving. Okay, so I'm going to go over hypoplastic left heart syndrome, and I want to talk about, how we understand the counseling for this can be very broad, but we are trying to identify whether fetuses are standard risk and high risk. And then we also understand that in the long term, predicting how well a child is going to do can be very difficult prenatally, just because the morbidities are extremely variable. But our job in this field is to really stratify this in utero better, and really more focusing on the perinatal management, but be able to better prognosticate and counsel our families. The lungs here are critically important in tolerating single ventricle palliation, so that is probably one of the key findings. From our survey this summer, it seemed that HLHS was the second most common indication for referral. So this is something that many people are probably imaging in the HLHS spectrum. So the objectives that I'm going to go over is what are these questions, but I think the main one is about the lungs, what makes up the standard protocol, who should be involved, and normative values that we have when we're reporting, and then how it impacts the clinical decision making, and then some further questions that we can hopefully hash out in the coming years. So fetal echo is the mainstay for diagnosis. It's relatively easy to obtain, good resolution, and the vast majority of time we can make the anatomical diagnosis and the variants specified very accurately. You could probably identify and measure the aortic and mitral valves well, see the flow patterns, and look at the PFO well. But what can MRI add in HLHS? So the lung health can be, I think, better delineated compared to fetal echo, and we want to see if this can better predict the degree of critical illness after birth. The further questions are how about the success of single ventricle palliation, and then there's these specific variants that we talk about, which is HLHS with intact or restrictive atrial septum. There's some institutions that are doing fetal intervention for atrial stenting, then HLHS with anomalous pulmonary venous return, and then also with genetic comorbidities, things like Kabuki or other trisomies, or other specific or non-specific genetic syndromes that might be popping up on different genetic testing. So the abnormal lung patterns that we can see, they can be related to increased pulmonary venous pressure, and that changes the pulmonary vasculature, causes the lymphatic channels to become dilated, and you see increased lymphatic drainage. So when we talk about pulmonary lymphangiectasia, we're describing the finding of seeing these linear tubular structures, which are these lymphatic channels that radiate out from the hilum towards the pleural surface. And there's a decade or so of older literature, which has really, I think, scared people in saying, this is a very high mortality rate, which I think is true. But I think that it's maybe not like black and white like that. So this is from this paper that you can see here a dilated thoracic duct and some streakiness as well as some brightness of the pleural surface. And this is T2 weighted imaging that we're utilizing. And so I have a case here. This was a 33-week fetus with hypoplastic left heart syndrome and had a type B pulmonary venous Doppler pattern with a borderline VTI of the pulmonary veins forward to reverse ratio was less than 5, but not horrible by echo. And so I'm just going to pull this in here. So you can see this is the lung imaging T2 weighted stacks in multiple planes, but I think this shows, well, there's definitely some hyper intense streaks here radiating out towards the pleural surface, and you can see those here. So this baby actually has gotten a Glenn successfully, which is, again, it's important for the team to know about this, but this was sort of a borderline finding. But even with this diagnosis here, the baby is tolerating their Glenn well and is doing well as an outpatient. So I think some of the limitations to be aware of is that we don't really have a great grading system. Obviously, we're working towards that as a field, but it's not established to be very clear on if you have pleural effusions or fluid or hypertense streaks, are they equal? And how does this really associate with outcomes? I feel that we have not really been able to have a clear prognostication with the different types of T2 weighted findings that we have. And I don't think that having this finding definitely is a death sentence for you. So this paper here, though, this is like from 2016, but this is kind of what people are looking at, which is the nutmeg lung group. While it was small compared to the overall group of hypoplasts, they had 100% mortality, and compared to 35% mortality, which is what we think of in our hypoplasts. So I think this definitely scares people and scares surgeons in terms of offering candidacy. So it is really important to hash this out more, I think, in the coming years in our field. So the structures that we aim to see on our imaging, so we talked about the lungs, so the appearance, the size, estimating your lung volumes, and then looking at the intracardiac anatomy. Hopefully you're not finding anything greatly different from echo, but seeing pulmonary venous return and dilation can be helpful. You can also assess for decompressing venous channels in the setting of restrictive atrial septum or intact atrial septum. The left atrial size. The atrial septum can be challenging to see at times to really identify like a septum if it's really thin. If it's thick, I think that can be a little easier. Looking at the AV valve regurgitation and systolic function. The size of the aortic valve can be a little bit challenging to measure, and I think echo is a little bit more superior. And then looking at the arches and getting some dimensions. So in some hypoplasts, the ascending aorta can be very small, and so I think it's a little challenging if it's a sub 2 millimeter ascending aorta. You may not get great resolution of this. So for a standard protocol, these are the things that we felt were most important. So lung assessment, really doing dedicated T2 weighted imaging stacks in multiple planes aligned to the fetal thorax. So you want to make sure that you're covering the whole fetal volume. You may want to increase your slice thickness compared to the slices that you might seek the parameters that you might be using for your slice to volume reconstruction. So instead of doing it 1 to 2 millimeters, really increasing that thickness. But be very mindful of the vendor, your field strength, the maternal body habitus. All of this may impact the appearance of fetal lungs. So if you are comparing a Philips scanner to a GE scanner, things are going to look different. So you really need to know what is normal on your scanner. Then including some cine imaging to look for the things that I mentioned on the other page. And you can use Doppler-derived ECG for cardiac gating. There's also other methods. A 2D to 3D slice to volume reconstruction for your anatomical views, and North has the pipeline for that. And then getting a fetal volume assessment, which there's some automated ways to do that, although we haven't had a clear consensus on indexing the fetal measurements. But this is probably less important in HLHS. So some unclear clinical utility measures would be like hemodynamic assessments in this lesion. The appearance of AV valve regurgitation, I think, is challenging. I can show you I'll show you some comparative imaging of what TR looks like on fetal echo and then what it looks like on CMR. And I think that it's quite hard, and the flow assessment may not be like consistently reliable. So I think there's some progress to be made in that realm. So this next case is a 31-week, 6-day fetus. So this is a fetal echo. It's hypoplast, and the tricuspid valve prolapses, and there's a significant amount of regurgitation, which was felt to be at least moderate to severe in this fetus. And so this is the fetal CMR. So we have some cine imaging here in a 4-chamber plane. And so this is the same tricuspid valve. So you have clear prolapse, and you have the dephasing jet, but it is, I think, challenging really to grade this well. And it's probably at least moderate, but this is a comparative image to what we saw on the fetal echo. And then we also did some lung imaging here, which did not show significant worries in terms of the T2 weighted imaging here. You don't see a lot of hyperintense streaks here. So similar to what others have said, still recommending co-reporting, but especially in this lesion, making sure that a fetal radiologist, you're doing a combined consensus on how you're going to report the lungs, because this really does impact how the medical team feels about what they're going to offer for the baby. So you should come up with like a consensus between your group about how you're going to report the lungs, how you're going to describe the lymphangiectasia lung pattern, and then it is important to have a double physician review of the lungs if you are going to call it lymphangiectasia. You should provide some segmentation. There's some normative values of lung volume, so I still use this paper. There may be other papers that are equally useful, but this is had a very large number of fetuses, and so you can go by just gestational age to get your lung volume normatives. The last part of this really is like the decision making. So fetal intervention is coming up as being useful in several lesions, but specifically with relation to HLHS, intact atrial septum or restrictive atrial septum is an area that it's been utilized. And the information that you can gain from an MRI will help individualize your counseling to the family, making sure that you're getting appropriate prenatal consults, and whether your delivery plan, if things look all right, then we're doing an all hands on deck high risk delivery versus, there may be supportive information that allows your family to get better feeling around transitioning to comfort care if things look not well. So when you just look at some predictive values here that we had, this is from a paper from JCMR, but in hypoplas, we look at the 1-year survival. These are similar numbers to what we had. And then TAPVR, we expect very good survival in repaired TAPVR. But when you combine this lesion, for those, it's quite a dismal prognosis in that, this just had one patient, but people, again, still worry about this and say that no one's going to survive this. So, the understanding of how the lungs look can either help reassure people that maybe there may be things that could be offered to help give the family some options. So this is a patient who underwent fetal intervention, and you can see this is what the TCH team has shown that improving the atrial restriction by placing an atrial stent can show improvement in the degree of lymphangiectasia. So it may make your team more willing to proceed with palliative options. So this last case is a 32-week, almost 33-week fetus that has heterotaxy, dextrocardia with the single ventricle. That's a severely imbalanced AV canal defect, and this is a hypoplastic left heart. There's unobstructed outflow tracts, so the pulmonary and aortic valves work well, they're open, and then there's suspicion for infradiaphragmatic TAPVR. On the echo, the mean gradient was around 2. And so here I'll pull this case in, but you can see this is the 3D reconstruction here that we have. The pulmonary veins are all returning to the cystic structure back behind the heart. And so if you follow this down, you can see this vertical vein that is draining, and it goes into the liver here at the IVC level. So this patient is still in utero, but the lung imaging looked reassuring. So there was no pulmonary lymphangiectasia that was of significance. And so the options that we've offered to the family is really comfort care versus trying transcatheter stenting of the ductus venosus postnatally. And they've opted for the latter. And so really it's going to be a wait and see approach about whether the baby would become a candidate for surgical intervention, which would be a TPVR repair and PA banding, but not within the first month of life. So the influence of the fetal CMR scan, very subtle lung changes may be difficult to interpret. It's hard, I think we're still at a place where it's hard to rate this, whether you see this being very mild or moderate or severe. I think the severe cases and normal cases are easy, but in the middle it's hard. But it's still important, I think, to recognize that these changes may still reflect an underlying lymphatic abnormality, and those things can be treated with maybe pulmonary vasodilators after Norwood and can get the patient to their next stage, and it may not universally be associated with 100% mortality. So our wish list items really is getting some feasibility for how to grade the lungs across centers, across vendors and magnet strengths. And then from there going with clinical outcome studies for how these different gradings impact how a baby will do either after birth and then in the long term. And then incorporating fetal CMR criteria for fetal intervention, also just for risk scoring, incorporating that with what we see on echo, and then being able to grade AV valve regurgitation, I think a bit more specifically and accurately. So that's what I have. Thank you so much.
Thank you so much, Manzi. I think, Heidi, in the interest of time, we're probably going to carry on and then take questions at the end of the kind of 3 left heart structures.
Yes, we can. And we have a change now. We will continue with David. And after that, we keep now to COA, and after that, we do the borderline. So David, please share your slides.
Thanks, guys. Can you hear me okay?
Yes, I can hear you. Perfect.
Okay, let's see if I can just bring this up. Okay. Oh, it's covering the screen. Exciting. Okay, can you see that? Okay.
Yes, we
Yeah.
can see it well.
Yeah.
Okay. Okay, thanks. Yeah, so I've been given the task of telling you how to diagnose coarctation of the aorta with cardiac MRI, which is a difficult problem. I think it's a common problem. So this is this was actually the results that were from the questionnaire that Malenka put out during the workshop in York a few months ago, and this was just people voting for what they felt would be useful applications of fetal CMR, and you can see coarctation was right up there with, I think, hypoplastic arch. And this is our data from our referrals for clinical fetal cardiac MRIs, 400 patients over about a 4-year period. And it is by far the biggest group that we see here as well. So it's a big problem. Now, there was a sort of bullet list of points that we were trying to get to with these presentations and try and get some consensus about. So this is one of them. What's the key question we want to ask be answered from fetal CMR? So I think the question for me is, can we actually predict duct-dependent postnatal coarctation of the aorta, i.e. early postnatal coarctation, which is dependent on the arterial ducts, where these babies can get very unwell without prompt treatment and intervention. Sequences we could use, I mean, I think you'll see a lot of different sequences. I think it's pretty much the same sort of thing. So we have these black sequences, single shot fast spin echo on the left, which are quite good actually for looking at the vasculature, and they give you this nice contrast to the vessels against the lung field, and then balanced steady state free precession, where you get this bright blood imaging, and you can either take still images like this one, or you can take real-time images, gated images, for various methods, and slightly better for looking at the intracardiac anatomy. But you can also see vessels and other things, and most people are applying some combination of these sequences for their imaging. So this was another sort of question that came up in the workshop. What sort of structures would we want to assess during coarctation, a study of coarctation? So there's a lot, and in the interest of time, I'm not going to kind of go through them all, but the vascular measurements, aorta, transverse arch, isthmus, descending aorta, the distance between the second and third branch of the aorta, displacement of the aorta, which I'll come to, ductal arch diameter, mitral valve, tricuspid diameter, aortic sidedness, ratios between different structures, so the displacement, descending aorta, again, I'll come to that, arch, and you could do a lot, basically. You can measure everything. If you can think of it, you can measure it. I don't think there's any consensus about what we should or shouldn't be measuring. And I suppose it comes back to that original question is, can we accurately predict duct-dependent coarctation of the aorta, whatever we're measuring? And I'd probably dwell a little bit more on that during this talk. So this is echo data. This is a big meta-analysis, which many of you will be familiar with. This is looking at various different markers from echo of trying to predict coarctation of the aorta. And the key thing here, massively busy slide, but the key thing is, bar the top one, which is this angle between the ascending aorta and descending aorta, we couldn't replicate that. Most of these just aren't very good. You know, they fall down with sensitivity or specificity. They're not very accurate tests, and we just simply don't have an accurate way of predicting early postnatal coarctation of the aorta by any modality, be that echo or MRI. But perhaps we can add something with MRI, and perhaps we can address this. So we attempted to do that. This is a few years ago now. We were using motion correction, which again, I think has come up a few times, motion corrected black blood imaging, and using that to generate these slightly more, if you like, reliable 3-dimensional imaging of the fetal vasculature, not the heart itself, but the vessels. And in so doing, thinking, well, can we maybe measure things in a little bit more detail? If we have this, it's more reliable. We can get this for more patients. We could actually start looking at some of these metrics, perhaps just in a little bit more of a granular way. So these are the types of things we measured. It's all in the paper. And again, I won't dwell on it too much, but we combine this with flows. So we looked at flow in the aortic isthmus, flow in the ascending aorta, and we took various measurements. So we did measure between the two, the left contralateral, left subclavian. We looked at the angle between the isthmus and the duct, that displacement, which turned out to be the key factor there, and the descending aorta diameter. And when we threw all that into a regression model, we had about 50 patients. The two things that came out to be strongest predictors, everything was basically predictive, but I think you find that whatever you look at, it's it's predictive, but it's just not specific. The most predictive things from this were the ascending aortic flow and this displacement, or analogous to the posterior shelf, this displacement or malalignment of the aortic isthmus with respect to the descending aorta. So yeah, as I said, we combine that with flows. Again, I won't dwell on this too much. I think the key thing here is to say that we did see differences. So the ascending aortic flow was certainly lower in fetuses with confirmed coarctation, but it was also lower in the false positive group compared to the healthy controls. And I think this just throws another big curveball into this diagnosing coarctation of the aorta, separating out the true positive cases from the false positive cases, which is the big problem with trying to diagnose coarctation, is that false positive group aren't normal. There probably is some unusual asymmetry. There probably is reduced flow through the left heart for some reason that we don't really understand. And that essentially mimics what we see with coarctation. So there's this other layer of complexity, I think, for a lot of these patients, that they probably are subnormal for some reason, but we don't know why. And perhaps that's a direction for some of the future work in this area. So we could actually then model the risk. So we can take those two parameters, the ascending aorta flow, which is here along the top of this table, and the displacement, which is along the left, which we index to the size of the descending aorta, and we can get a percentage risk. So it's not a diagnostic test. It doesn't tell us whether the fetus is going to have coarctation or not, but it gives us a risk. And actually, that's potentially useful. The question then always comes, well, how do you interpret that risk? And that's a difficult question, and I think we've probably found a relatively nuanced one. This was another question in the brief, which we include in the report. So this is an example of how we report that. So we have a full report, we include the flows, we include all of our measurements, we include some imaging data, either from the bright blood imaging or black blood imaging, some segmentations, and we include the risk. We include the risk that we've calculated. Now we could just give the risk, but I think the reason I wanted to put this up is to say we're presenting all of this information back to the referring clinician. There isn't an obvious yes, no answer. There is a risk, but within this, there's a lot of potentially additional information for which they can also draw subjective judgments. And they've seen these patients, they've scanned these patients, so it all feeds into that decision making. And I think that's the key points I wanted to make. Decision making, it is nuanced. There isn't in one center for one patient, there isn't going to be one answer where you can say, well, this is what I'm going to do for that risk. This is just a map of the centers in the UK that perform cardiac surgery and where the patients come from to go there. But you see, we cover huge areas. There's big gaps everywhere. This is, I'm sure, the same in many different countries. Some of these centers are co-located with neonatal intensive care and obstetrics and all of the other people that you may need. Some are not. There's a lot of decision making that goes into making the right decisions for patients. Also, as I said, a lot of these patients are going to have been seen several times by a fetal cardiologist or whoever's seen them prenatally making that diagnosis. They will have had multiple ultrasound scans. They will have some idea of the longitudinal changes that they've seen over time. They'll have their own impression, their experience, all of these types of things. There's a risk that they already have of that condition, or they've already perceived of it. And like a Bayesian approach, when we add something in from the MRI, it's probably just adding to that a priori risk. It's adding to some previous judgment. It's not something I think certainly we or anyone I think at the moment can say, this is definitely going to be coarctation of the aorta, this is what you need to do, unless it's an absolutely barn door case. But to be honest with you, they're not usually the problematic ones. No low risk doesn't equal no risk, so, and the other way around. So either if we say a low risk of the condition and they have coarctation, then that is perhaps something that you might expect, certainly over a large number of patients. So I don't think there's an easy answer to that question, and I think it's something that feeds in, but I think it's still potentially useful. So here's just some very brief examples of some of the cases that we've seen of the many cases we've seen. I'll give you a few brief examples, but I think perhaps what's more useful is just giving you an overview of how these kind of tests really perform in practice. So this was a case that was referred to us with high risk of coarctation of the aorta. For those familiar with echo, you can see that the aortic arch certainly looks quite slender here, possibly a little bit of flow reversal at the isthmus. The arch measures 2.5 millimeters. It's a Z score minus 3.6. So definitely below the normal range. This is at 34 weeks, but that's a persistent pattern in the pregnancy. There was some ventricular asymmetry. The aortic valve also measured a little bit on the small side. So this is your classic, you've just got these features you can't ignore, and putting it together, this was referred as a higher risk for coarctation. We put everything through, particularly based on the ascending aorta flow rates and the displacement. We actually came with a very low risk, and that's what we reported. It didn't particularly change management. I think in this case, the fetus has already been transferred based on the previous imaging, but there was no coarctation of the aorta. So perhaps you can say, yes, okay, that's good. That's a win for MRI. We were accurate, or at least the risk that we gave seemed to be accurate. Here's another case. So this is a high risk coarctation, bilateral SVCs with a ventricular septal defect. Again, on the left here, very similar kind of picture. You've got this smaller aortic arch, antegrade flow, and they were concerned here on the sagittal views. Always difficult to know exactly where you are here, but certainly it looks very slender, the aortic arch. And on some views, you think, yeah, maybe that's a bit displaced. We did the MRI, and in that 3D imaging, I think it shows it really clearly. Yeah, we measured quite a big displacement here, and unsurprisingly had a very high risk of coarctation. And this fetus also didn't have coarctation. So it's difficult. And I think we spent a long time pondering and trying to work out with our colleagues, how can we make this, is this useful? Is this useful giving this risk? And actually, if we said 90% risk, we didn't say 100, we can't say 100, and there was a 1 in 10 chance of this fetus not having coarctation. So were we right? Were we wrong? How do we deal with these numbers in practice? And perhaps what's most useful actually then is to start saying, well, how do they actually perform in the real world? And this is some data from Thomas Woodgate, where we've actually looked at the performances now prospectively. This is over 90 cases. On the left here, you see the group that didn't have coarctation repair, and on the right, the ones that did. And you can see the dots represent the coarctation risk. So we have these cases, yes, where we gave a higher risk and they didn't have coarctation, and some where we gave a lower risk and they did. Most of the cases are still grouped over at the end, but actually when you look at how this model is performing, accepting that some of these cases would be expected to have coarctation, even if they're coming in as a relatively higher risk or lower risk, then it actually performs very well. What we want to do, of course, is just get rid of those, and then we have a binary test. We have a test that we can say it's a yes or no answer, and I think that's just sort of sum up all of that. I think that's what we should continue to work towards, and I think that's the kind of future direction that would be pretty valuable with fetal CMR. And there's lots of different options for that, lots of different avenues. So this is some of our work where we looked at statistical shape analysis and tried to model some of the flow and the relationship between flow and shape. And actually there's quite a strong relationship between the shape of the aortic and isthmal interface and the relative flows in those vessels. This is some work, you've seen a bit of 4D flow. This is from the group in Bonn looking at 4D flow. I think you'll see more and more of this, and I think this could add some real insights into the development of coarctation, particularly at that vascular level, what's actually happening there. Is this the clincher? Is this the thing that's going to help us diagnose this more accurately? Similarly, this is the group, Sally Ann Clare's group in Amsterdam, again exploring 4D flow. So I think this, the physiology and the power of MRI really coming to the fore with these types of things. We've looked at giving maternal hyperoxygenation and then measured the responses in the fetus, and in a group of patients with coarctation wasn't discriminatory, but there were some signals there that actually maybe testing the physiology in this way may be helpful. And we've currently got a study running called the Placard study, where we're really zooming out a lot and still focused on coarctation, one of the primary lesions we're focused on, but starting to think about, well, why is there this imbalance between the left and right heart? How does that fit within the whole fetal placental circulation for those that have coarctation and for the false positives who I said are clearly subnormal in some way? So to summarize, a whirlwind tour of a quite complicated topic, but it's a challenge, and I think how you apply fetal cardiac MR for this is tricky, because we don't have any confirmatory test for coarctation, particularly for those grey areas, and those are the kind of questions, those are the ones you'll be referred, the ones that are difficult to diagnose. it's still heavily reliant on subjective risk assessment in practice. And I think actually perhaps the best we can do with MRI is make that subjective risk an objective one. It has a number. This is what we think the risk is. And, you can at least start building on that. But, when it goes back to a clinician, I think actually how that risk is interpreted still has lots of subjective layers. I think the key thing, and I think from our point of view, is just to report openly, report what we know, report what we don't know, and do that side by side with the teams referring, and just build up that confidence. And I think I always have in the back of my head all the other things we're doing along the way to try and improve things. So, we're not staying still. I'm sure we'll get better at this, but, bringing your colleagues along is important. And I think that's it.
Thank you very much, David. That's a really interesting run through the trickiness of coarctation and its diagnosis. Heide,
Yeah, thank you,
to you for
David.
the last talk.
Highly interesting. Thank you so much for this insight. And yeah, even though it's already 5 p.m., we will, of course, keep going. We have one more indication left, and this will be presented by Eleanor. So it's a borderline left ventricle. And yeah, thank you, Eleanor. Very happy to hear your insights. Are you there? I cannot hear you, Eleanor. You're still muted.
Thank you so much.
All right.
All right. And then just to share my screen. All right.
Yes, I can see your slides.
Okay. Excellent. All right,
Good.
so I'm Eleanor Schuchart. I come to you from Rady Children's Hospital in San Diego, and I'm going to be talking about borderline left ventricle. So the key question for fetal CMR when it comes to borderline left ventricle is a big one, obviously. It's like you want this baby to be successful at whichever pathway is pursued, and so which pathway is the right one? But on a case-by-case basis, so that's a big question. On a case-by-case basis, there's a lot of nuance to this diagnosis. On each individual case, are there details of the anatomy that are yet to be defined or that could be defined with a higher level of confidence? This is an area where fetal CMR is a supplement and not a replacement to fetal echo. And then can fetal CMR help refine your prenatal counseling? I can speak from personal experience that explaining the various pathways of Norwood, hybrid, two ventricle repair, and the risks and potential complications of each pathway to an expectant mom is a difficult task. So I have a few cases kind of sprinkled in here throughout my talk, and this is the first one. This is the little ventricle that could. Here on fetal to back up, this fetus came to us in the second trimester at 20 weeks and had a quite hypoplastic looking left ventricle, but that consistently reached the apex. And then in the late second trimester, the atrial septum appeared to close and the left ventricle got a little bit bigger. So we came to the MRI scanner to look at the lungs and assess the left ventricle. Our left ventricle here was quite small at 1.5 mLs or 0.5 mLs per estimated kilo, or an index volume of around 8. The z-score being negative 3.7. And then this baby got born and went on to have a ventricle that looked like this at 5 days of life. Had a fairly rough transition into neonatal life with early ventricular dysfunction, and the ventricular volume from this scan was 26 mLs per meter squared. And so then we were still kind of borderline with this left ventricular volume, and not sure exactly which pathway to go down. This fetus also, or this baby also had coronary cameral fistulas that were risky to put on bypass from a myocardial protection standpoint. So we waited, and here a little bit later at 3 weeks and 4 days, that left ventricle grew further. It came up to 10 milliliters and an index volume of 49. So that baby ended up going down a coarctation repair, had a surgical aortic valvotomy, and is now progressing clinically, although slowly. So I've kind of organized the structures to evaluate, the parameters to measure, and the sequences to be used into a table. So you'll see some repeats down in the sequence portion. It's meant to, each line kind of, each piece adds to what you should include in your protocol. But obviously you want to evaluate the left ventricle, its size, its function, its stroke volume. And to do that, using your short axis stack with your balanced SSFP and your 4-chamber synase. To assess the mitral valve, you want to assess the annular size, the inflow, aortic valve, again, annular size, and ascending aortic flow. The right-sided structures are important to image just because many things can be relative. So generating a ratio of the right ventricle to left ventricular stroke volumes, the tricuspid to mitral valve, the aortic arch is important as there's left-sided disease in multiple levels of left-sided disease in these patients, and then getting an estimated volume of the fetus for estimation of fetal weight. So when it comes to normal values for reporting, this from the group in Denver, Minocha is the first author, and this is what we've been using to kind of quantify our ventricular volumes and provide Z-scores. In terms of, in our workshop in Leeds, in York, we had a lot of discussion about the best ways to index the fetal volumes, and keeping in mind that we're jumping from the fetal life into the postnatal life. These normative values are in mLs per kilogram, but in neonatal life, much of the normative data and the predictive data is in body surface area. So since our workshop, I did a little bit of lit search and found this paper out of a group from Sweden, which looked kind of tried to define the best equation to use weight only to define the BSA. And so I've started using this and reporting both in mLs per kg and in mLs per meter squared to just kind of get a better sense of what how to observe how people consume our reports and how this data can be followed over time for each individual patient. So I think we're going to continue to have this great debate. How should we index? Who are the consumers of our reports, and what is the margin of error in our calculations? And then we were asked to comment on who reports these. I think a pediatric or a fetal cardiologist or a radiologist with a high level of CHD understanding should be the primary reporter. Extra cardiac findings are less likely with this indication. And then, the big question of how much certainty should we claim from the fetal CMR. My experience thus far has been that the more you know, the less you're sure of. I'm somewhere here in the Valley of Despair or the peak of Mount Stupid. And now on to some clinical cases. So this was a G1 fetus at 34 weeks gestation with small left-sided structures developed. Diagnosed in the kind of mid-second trimester. Our mitral valve was mild to moderately hypoplastic with a Z-score of -3. The orifice shape seemed normal. The papillary muscles seemed normal, but the left ventricular volume was 2 mLs for a volume of 0.9 per kg or 12 mLs per meter squared. Our length LV length Z-score was also low, but the function was normal. They also came to us with concern for coarctation. So a lot of David's talk applies here as well. The arch appeared angulated and had a small amount of anterior displacement and kind of a right-left oblique plane. The isthmus measured good size, though, at 2.9 millimeters. So in this patient, our relative flows were that there was much more flow going through the right heart versus the left heart at 3.0 for a tricuspid valve to mitral valve ratio. So I read this overall as a probable coarctation and mild left ventricular hypoplasia. Well, here's what happened. A baby got born and laughed at us, had a more reassuring appearing aortic arch. The arch was challenged and was shown to have no significant obstruction, but the baby kind of had what we've kind of referred to as a malignant ASD physiology with left ventricular diastolic dysfunction and a high shunt. Required inotropic support and slowly made progress. Baby was discharged home without any intervention, and the genetic information resulted with a variant of unknown significance, but that is active in the TGF-beta pathway. So that may account for some of our left ventricular diastolic dysfunction, and it's yet to be seen the remainder of this baby's course. So just go ahead to our next case. This was a double outlet right ventricle with subaortic VSD and a hypoplastic mitral valve and a long and slender left ventricle that was quite hypoplastic even early on in the pregnancy. The great arteries were side by side and there was an intact atrial septum. So this pregnancy was also complicated by fetal growth restriction. Baby came to us at 33 weeks for a fetal MRI. And our estimated fetal weight was in the 15th percentile. So we did a hyperoxia test, and here's our room air results. The left ventricle was about 0.9 mLs or 0.5 mLs per kilo of estimated baby weight, 6 mLs per meter squared, z-score of -4. Wasn't putting out much cardiac output for about 100 mLs, where the combined was 440. And our mitral valve, our tricuspid valve to mitral valve ratio was 4.5. And then placing that mom on oxygen, we allowed 10 minutes of equilibration time, 8 liters non-rebreather in the scanner. The images were very challenging. So, but I do subjectively think that this ventricle increased in size. The left ventricle came up to 1.1, 0.6 per kg, or 8 per meter squared. The overall cardiac output increased slightly, and that tricuspid valve to mitral valve ratio was unchanged. So overall, it was a 27% increase in our end diastolic volume. Our 2D mitral valve measurement increased, and the mitral valve flow was stable. Clinically, like, this baby went on to have no neonatal intervention. The mitral disease became more and more significant throughout the early infancy, developed severe stenosis, had a supravalve mitral membrane and arcade appearing valve. Their CMR at 2 months showed a LV end diastolic volume of 32 mLs per meter squared. And at 4 months underwent a mitral valve repair, ASD creation, VSD enlargement, and a PA band, with a plan for a 2-ventricle repair down the line. But we're still in that recovery period from the PA band. So lessons learned for me from this case is that, you know, a hyperoxia test may be helpful in the cases of borderline left ventricle, and that I think, given the opportunity again, I would scan this patient a little bit later, given the presence of fetal growth restriction. Just get this baby a little bit bigger to help our image quality. And so the research questions and future directions for this area is, could serial fetal MRIs be helpful? Is there a trend that we can pull out that is meaningful? And what is the best predictor of LV potential? What's the role of hyperoxygenation? Is it just an academic discussion, or is it actually helpful? And can predictive modeling do better at showing us which path would be the right ones for the borderline ventricles. Yeah, and how do we study the diastolic capacity? So when the volumes change with fetal to neonatal transition, it would be wonderful to predict that. And so for now, we just keep swimming. Thank you so much.
Thank you so much, Eleanor, for this insight.
And that was a really inspiring talk. I think we still have a distinct lack of questions. Everybody is stunned into silence.
Is there anyone who wants to raise a question to our experts? Now it's your chance. There was some discussion with Christian, but I think that has been discussed with Eric and Richard already, which is great. Otherwise, if there are more questions, you can also come back afterwards to us, and we can connect you to each other to continue such discussions if you want to. Yeah, with that, we are at the end of our autumn webinar session. I would like just a quick shout out to the workshop in Denver. It's already in October, mid of October. So North Medical, we will be there, and we hope to meet some of you to continue discussions and to continue, to talk about clinical cases and to talk about the next steps of research. And there's a special focus on fetal cardiac MRI. So happy to meet you there. Having said that, we'd like to thank, of course, as always, the Fetal Heart Society as a supporter for this webinar and for the good collaboration, as well as, of course, Society for Cardiovascular and Magnetic Resonance, the SCMR. And last but not least, for feedback or any other topic of interest, also for the following webinar sessions, and as I said in the beginning, for the magazine, feel always free to contact us. And for the future, please directly contact my colleague Lea. As today, this has been my last webinar session. My colleague Lea will take over this task in the future. And having said that, I would like to thank all the speakers today for this very good and successful, interesting session and the whole amazing collaboration in the past. So thank you all for this, for your attendance and for this session. Bye, everyone.
Bye. Thank you so much, Heidi. We'll miss you.
Yes, we have to take the opportunity to shout out to Heidi, who has organized these webinars for so long and has grown this educational community into just a really fun group of friends.
Thank you so much. It's going to be continued. I think this is just the beginning, and it's going to be continued. It's great, and I'm happy to have you all and happy about this cooperation. Thank you so much.
We'll miss you.
Thank you.
Thank you. Miss you too. All right, guys. Thank you very much. Have a good day. Bye-bye.